Make it cozy.
So I don't feel lonely.
Exactly.
Are we on? Is mic on? Mic on? Yes? Good. All right. Well, welcome everyone. I'm Cortland Childers in the Department of Medical Education and have the privilege of introducing our speaker this morning. Dr. Kimberly Manning is originally from Los Angeles. She did her undergraduate studies at Tuskegee University in Alabama and then medical school at Meharry Medical College in Nashville. She then completed her combined internal medicine pediatrics residency at Case Western Reserve University in Cleveland, where she also did her chief year. In 2001, she joined the Division of General Internal Medicine at Emory University, spending her clinical time divided between the inpatient and outpatient services at Grady Hospital. Dr. Manning holds an academic appointment as an associate professor of medicine and currently serves as the program director for the transitional year residency program at Emory. Her academic interests include humanism in medicine, leadership in medical education, and reflective writing. Her work has been accepted in publication journals such as the Annals of Internal Medicine, JAMA, and Academic Medicine. She has been awarded numerous teaching awards in both the residency program and School of Medicine. And this morning she'll be sharing with us her talk, The Patient as the Teacher, Timeless Lessons and Teachable Moments. Thank you.
Thank you. Hi, everyone. Can you hear me okay? I don't know if this mic is on yet. Is it? Good. Okay. So I'm usually not a stander, so just consider this a big hug to all of you. I'm normally a walker, but I'm going to be up here so that I can advance the slides properly. Just want to first say thank you so much for having me here today. I was really delighted to be asked. I've never been to Portland, Oregon, and you can thank me for the snow that I brought you. Despite that really nice introduction, I have not yet reached big deal status enough to have anything to disclose. So sorry, I don't have anything to disclose. One of my mentors told me to always start any lecture with gratitude so that you don't forget people. And so for many of you who are here in Portland, you know that this is Donald Olson, for whom this lectureship that I was invited to do is named. And specifically, I was asked to come and focus specifically on humanism in medicine, which is great because that's an interest of mine. When I heard about the name of the lecture, I did a little bit of background and learned more about the life of Dr. Olson. And one of the things that stood out to me when describing him, someone described him as a role model physician, teacher, and human being. And most of the things described about Dr. Olson talked about his deep allegiance to the patient-doctor relationship, and also bringing learners to the bedside to appreciate that. And so, though I haven't quite figured it out to the level of Dr. Olson, certainly, like all of you, I deeply care about the patient-doctor relationship and about learners and helping our learners to see the very best in our patients and recognizing that we are all always students. I'm now PGY 22, I'm proud to say, and our journey together will be about patients teaching us. This is Grady Memorial Hospital in Atlanta, Georgia. Anybody been to Atlanta, Georgia before? Nice, good. So Grady Memorial Hospital is our safety net hospital and does the lion's share of the teaching services for Emory University. I moved to Atlanta after my residency for Grady. I wanted to take care of patients there. And what I found out is that what started about 16 years ago was a second residency that I'm still in. And most of it has come through the power of spending time with patients. So 25 plus years ago was 1992. And in 1992, I was a first-year medical student. And a lot was different back then, not just the fact that we didn't have a lot of the things we have now, also this very tragic choice of lipstick that I had But otherwise, things were really different in 1992. We didn't have any laptop computers as medical students and residents. And if you did have a laptop computer, I don't know what you were going to do with it because there was no Wi-Fi hotspots anywhere. It didn't matter if there was a firewall because there was no Wi-Fi, so you didn't even know what the internet was then. I have no idea how I knew where to go or what to do because I didn't have an email address, and so I don't even know how we knew the things that we did know. We spent all day in class. We would go to class at 8 o'clock in the morning and sit and listen to somebody lecture in front of a room until about 4 p.m. And there was no, thing on iTunes where you could hear the podcast version at 1.5, which is what the students do at Emory. They listen to you talking faster than you talk, which is a funny thing. We didn't have that option. You had to sit there in real time and take notes into a little spiral notebook and maybe Xerox them and show them to your friends. Nobody had any of these things. And if you wanted to talk to somebody, now I see some people who look my age or older, so I'm sure you know what this is, but for the young people, this is a landline. It plugged into a wall. It would ring, and the only way you knew who it was is if you picked the phone up and said hello. So it was kind of like the Russian roulette of communication back then. Until 1994, which I really remember because that was when everybody started getting these caller ID contraptions to connect to their landline, so you would know who it was. You go, "Hi, Mom," and she'd go, "Oh, you have caller ID, how cool." And that changed. But then time started moving forward as I became an M3. Things evolved a little, but not so much that we got electronic knowledge. You see that thing in my left hand is a book. And that was how I learned on my clerkship. So finally, I graduated in 1996. And with 1996 came the internet boom. And with that, we all had email addresses. We all had these electronic ways to communicate with each other. And I got my first cell phone as an intern, which was exactly the size of the one that you see projected. It filled my entire trunk. And it was $100 per minute to call anybody. So a lot of us who are older remember that keeping a roll of quarters in your car at all times to pull over and return pages. But as time went on, things continued to change. These are medical students on one of my ward teams. As you can see, both of them are looking at smartphones and sitting in front of the electronic medical record at the same time. They can correct you on the spot when you're presenting something on rounds. You say something and they'll say, well, actually, that data is inconclusive because I'm looking here. And you're like, okay, great. And then they can even put in an order on the fly as they're standing in the hallway through an iPad. So as you can see, in 25 years, so much has changed in medical education, and you being a department of medical education, a lot of you have been here to witness a lot of that. But here's what's so cool. Whether you started your training in 1992, 1962, 1942, some things as far as your learning just do not change, right? If you start to ask people, regardless of when they trained, what the most pivotal, most important teachable moment that they experienced in their training was, it will not involve technology. It will not involve a paper. If you are in patient care, it will involve a moment with a patient. And so, though everything has changed, nothing is new under the sun when it comes to us as learners. The most powerful teachers that we have are our patients. And so today, what I'm going to be talking to you about is that. The parts that couldn't be learned from books, couldn't be learned from papers, couldn't be learned from the latest literature, but really was only learned through walking into the hospital and taking care of patients and then reflecting upon it. And given that this is a humanism series, I hope you'll come along on this journey with me as we go through some of these teachable moments. All right. You'll see a lot of images here, most of which I've taken myself. I'll use some names. They've been changed to protect anonymity. And the images that involve faces, permission has been obtained. Okay? So this is Cleveland, Ohio, where I started my internship Case Western Metro Health Medical Center, where there is lots of snow. So I was very used to that site this morning. And my very first rotation when I started as an intern in July was the hospital service, inpatient medicine. And the first senior that I was given was a woman who was notorious for being able to put a chest tube in with one hand and a central line in with the other, and could take her foot and code somebody at the same time. She was not afraid of anything. She was tough and had already, outside of the match, gotten into our critical care program. And she was my first senior, and she would say to us interns, listen, if you don't learn anything in your entire internship, all you need to know is one thing and one thing only, the difference between who's sick and who's sick. And we were like, deer in headlights in July. We're like, so what is the difference? You just need to pay attention. We're like, okay, Yoda. And so she would always talk about that. You just need to know if the person's sick or sick, yes or no. So it was constantly a stressful thing. But we paid attention. We watched her. We followed her where she went. We would ask her, is that one sick? No, he's just sick. Be like, okay. And so one of the first patients that I took care of that stands out for me was a gentleman. His name was Mr. Farrell. And Mr. Farrell was a man who had advanced COPD, was oxygen dependent, and also had bad peripheral arterial disease and had a non-healing ulcer on his foot. He'd been admitted for acute on chronic respiratory failure and had been very short of breath and also had this ulcer on his foot that we were having wound care see. For the most part, it wasn't a lot of active stuff going on with him. And so each day, you know, I would go in and see him, and we were trying to figure out his CO2 levels and what to do for this foot. But for the most part, he wasn't sick. He was just sick. And so each day when I'd see him, I'd come in super early in the morning because I was terrified and there were no duty hours reform. And so he would talk to me all the whole time about this Jack Russell Terrier dog that he had named JoJo. And it would be JoJo this and JoJo that, and JoJo this and JoJo that. And Mr. Farrell was up very, very early in the morning when I would walk in because he was always walking his dog first thing in the morning. And so that was my ritual for that first week and a half that I was on the service. So one morning after caring for him for about a week or so, I come in, crack of dawn. This is how the parking lot always looked when I arrived because I was so scared. And I go to his room, and the first thing I notice is that he's not sitting up. He's asleep. So I go to Mr. Farrell, and I say, Mr. Farrell, sir, Mr. Farrell, sir. And he kind of is groggy, and I give him a sternal rub, and he kind of finally opens his eyes, and I say, hey, it's I was Draper then. It's Dr. Draper. I'm here to see you. And he kind of sat up a little bit, and I said, okay, well, maybe he's sleepy. I checked his vital signs, no fever. He wasn't hypotensive, so I'm like, okay. So I listened to his chest, peek under the dressing and look at his foot, and just go off and finish doing my pre-rounds. We're walking through the hallway, and I talk to my senior resident, and I tell her that, you know, Mr. Farrell was a little bit different today. I don't know what was going on with him. He was just a little groggy. And she said, what do you mean groggy? And I said, I just had to wake him up. I mean, his vital signs were stable. Fast forward 3 hours later, Mr. Farrell was in the intensive care unit, intubated and on pressors. He coded probably about 15 minutes after I told her that. And so what she said to me was, what was different about him? And we started to go through it. My senior resident says, some things in medicine don't make sense, but most things do. Let's walk through what happened to him. His temperature was 35.5. Now, I was a July intern, and it was not yet in my fund of knowledge that hypothermia was a sign of sepsis. And so there was a gap in my knowledge, which I acknowledge. His respiratory rate was 22, and after working in a hospital for a while, I've learned that if somebody actually writes something other than 20, it means they counted. So maybe he was a little tachypnic. But most of all, he was asleep. This was very, very different for this patient that I had been caring for, and that was a detour. And so perhaps looking a little bit deeper, I might have noticed some more things about him. And so after that month, I started to get a good hang for who was sick and who was sick. And so by the spring of 1997, the second half of my intern year, I felt like I had enough swag to, jump on the back of a classmate and hold a cup of coffee at the same time. I was pretty sure of myself then. And by then, I took care of a patient named Mrs. Elmore. Now, Mrs. Elmore was a woman who had been admitted to our team on call, and she'd come in approximately 8 hours before I saw her. Her admission was for community-acquired pneumonia, and she'd been given antibiotics in the emergency department, and then my team was called. By the time I came to see Mrs. Elmore, 8 hours after she had what seemed like pneumococcal pneumonia, she looked great. She was not sick. This lady was happy and chilling and laughing, and when I walked in, she goes, "How old are you? Are you my doctor?" And I said, "Yes, ma'am, I need to take my history." We just laughed and laughed. So I asked her as I'm taking the history, "Miss Elmore, what were you doing when you got sick?" She said, "Girl, I was standing in my kitchen making a banana pudding." And I said, "Really?" Now, my family's from the South, so there's two ways to make banana pudding. You can make it no bake, or you can make it with like double boilers and meringue. And she said, "What?" And she walked me all through her recipe. So this was not a sick patient, because sick people, they don't talk about meringue and double boilers. They try to catch their breath. So I relaxed a little and said, "Oh, this is really great. She'll be out of the hospital in no time." All right. We look at her x-ray, and she had some fluid on her x-ray, and also it was commensurate with that on her exam, and so we do a lateral decube, as good interns do, and saw that her fluid layered out, which meant we needed to get a sample of that fluid. I had a good rapport with Miss Elmore at that point. I explained to her that we needed to get a little sample of her pleural fluid to make sure there wasn't anything too serious going on, and she obliged. We did a diagnostic thoracentesis, got a little bit of fluid. The fluid didn't look too scary, and that was that, right? But then I get this phone call. Critical lab, pH of 6.88. And I'm like, pH of 6.88 on what? And they said, on that pleural fluid sample that you sent down to the lab. On that lady? Oh, wait a minute. I'm sorry, this has to be an error. They're like, no. The pleural fluid you sent, the pH is 6.88. So all I could think about was this smiling lady who was nice to me and still talking about banana pudding as I stuck the needle in her chest. And I'm thinking, oh my goodness, I don't think that this lady looks sick enough to need a chest tube or have an empyema. And I remembered, some things in medicine don't make sense, but most things do. And this was not making sense. And so because we did not have the internet, as I told you already, I had to go to the library and see what Dr. Light and his colleagues had to say about this. And so I'm just thumbing through the book, hoping I can find one paragraph that says, okay, for everybody else you need a chest tube, except for a really nice lady who was making a banana pudding and who's laughing and says you look too young to be a doctor. Everybody else gets a chest tube, just not her. But unfortunately, what Dr. Light had to say was, she needs a chest tube, she needs a chest tube, oh, and she needs a chest tube. And so I stood there trying to figure out what to do, and then I heard my resident again saying to me, "Kim, does this make sense?" And that's how she said my name, Kim, all the time. So I still hear her in my head. And it didn't make sense. I sat and thought about it for a moment because I imagined sticking a thoracostomy tube into this lady's chest and said, well, let's think this through. Her temperature is improving. Her white blood count is already down. Everything going on with her is consistent with pneumococcal pneumonia that's really fairly uncomplicated. This isn't really making that much sense. And especially, she was well enough to talk about banana pudding nonstop with a needle in her back. And so I decide we should call our attending because we're in over our head. We need somebody senior to save the day and help us know what to do. I'd had the world's most indecisive resident that entire month. But in this moment, he was quite decisive. He was like, no, we're putting a chest tube in. You need to call surgery. I said, no, we need to call the attending. And this is exactly what he did. So he says, I'll tell you what. You can call our attending, who, did I mention, is the chair of medicine? And did I mention it was 3 in the morning? And he told us, don't page him at night. Just call his landline. So he said, I'm not going to have anything to do with you calling the chair of medicine to say, sir, somebody has a pH of 6.88 in their pleural fluid. Should we put a chest tube in? He's like, yeah, you're going to do that. And so I called my attending, the chair of medicine. And let me tell you what he did. He said, hold on for a moment. He got out of bed, went to a room, and he gave me 3 uninterrupted minutes of his full attention. He asked me to present the patient. He listened carefully. He didn't rush me. And I wasn't scared anymore. The tone of his voice and the way that he interacted with me really made me feel safe. And so because of his experience, he started to ask me questions, things that I didn't know. How much lidocaine did you use, Kim? What did you do with the specimen as soon as you drew it? Did you take it straight to the lab? Did you put it on ice? How did they run it? How long did it sit? And there were questions that I didn't know. And he said, if I were you, if this patient looks like you're describing, I would use that rapport that you built with her and go to her and ask her if you can take another sample. I know it's invasive, but putting a chest tube in her, if she is like you described, it could be that there's an issue with your sample. I went back to that lady. I tapped her chest again, and the pH came back 7.34. She did not get a chest tube. And the biggest, most powerful thing in all of that was, one, that 3 minutes of his time that he gave me. It was pristine, it was unintimidating, it was uninterrupted. But also that same 3 minutes was what it took to build a rapport with Mrs. Elmore and allow her to be willing to let us try this again and understand what was going on. And so I started thinking a lot about the power of 3 minutes, right? Because like 3 minutes is what it takes to make a cup of noodles, which is what I ate all through residency, which is why I had to put that there. And this 3 minutes was something that I saw in the elevator at Grady Hospital. A woman who worked for the cafeteria services and was in the elevator with me carrying a tray with food, and I said, oh, somebody missed a meal after a procedure, and she said, no. Every day when I go see this patient, there's nobody there to see her, and she's been in the hospital for a long time. I have to always check the armband, and her armband told me that today is her birthday. So I decided that I would bring her some cake. I looked for some candles. I couldn't find any, so I just put 2 squirts of extra frosting on top. And that took her 3 minutes. This is Piedmont Park in Atlanta, Georgia. Piedmont Park is this beautiful, wide open oasis in the middle, in the heart of the city of Atlanta. And this, in 3 minutes, is what was standing between me and Piedmont Park one day when I was working on Saturday in clinic. I have no idea how I took my first job at Grady when we used to have to work on Saturdays, but we did in the clinic. And so I had my final patient scheduled, and it was an urgent care clinic, and the chief complaint was on the sheet. And the sheet said, hemorrhoids, needs cream. I was like, yes, 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 I get to go home. And in walks this young man, healthy, young college student who tells me, I've had hemorrhoids for a long time. I'm an athlete. I do a lot of weightlifting. I do squats. I had them before. But I don't have the cream anymore that I had at home, and so that's really all that I need. And I'm like, okay, sweet, I'll give you your cream. And we start talking, and I ask him about his major, and we're chit-chatting and everything, and I say, you know, do I really, really need to look at his bottom? I mean, the man knows people with hemorrhoids know they have hemorrhoids. I don't need to confirm that the man has a hemorrhoid. And so I decide in that instant that I'm just going to write his prescription and let him go and then go to Piedmont Park and hang out with my friends, because that was before I got married. And then I sit there for a minute and say, what kind of really bad doctor doesn't look at the bottom of a person whose complaint is a hemorrhoid? I mean, it takes 5 seconds. So I'm like, oh, okay, let me do the right thing. I take a look at his bottom, and he doesn't have hemorrhoids at all. His rectum is almost completely occluded with anal condylomas. And I looked at him and I said, who told you you had hemorrhoids? And he said, my home doctor. And I said, did your doctor look? And he said, no. I said, has anyone looked at your rectum yet? And he said, I mean, I looked. I said, those are not hemorrhoids. I hadn't taken the sexual history. I hadn't asked him anything. I basically took his word when he walked in. I looked at him and said, he's a college student, and I sized him up. And so the lesson I learned from him is, one, unnecessary shortcuts can harm patients, and two, sizing people up is a recipe for disaster. And I'm still a work in progress with that, right? But but I always think of him when I'm faced with that situation. Now, instincts and hunches in medicine can't be completely ignored. With that last patient, I didn't really have a hunch that something more was going on. But sometimes you're in the hospital and there's a patient that you feel for sure, like there's something else going on with this patient. Something is not right. I don't know how many of you have ever read this book by Malcolm Gladwell. It's called Blink, and it's about the power of just our instincts or our first gut feeling about things. And there's certainly a role for that in medicine when combined with the things that we do. And so I thought of that as I saw this patient. This lady, Miss Moore, was a woman who came to see us in clinic one day after being in our emergency department at Grady Hospital. Now, if you've ever been in an emergency department in a safety net hospital, you know that it is like a long venture. It's an exhausting thing. And this lady had spent all evening in the emergency department for a hurt wrist and had been told that her blood pressure was slightly elevated and she should follow up in the primary care center. And so the very next day, she was in our primary care center for this blood pressure that at best was probably pre-hypertension. Well, real hypertension now with the new guidelines. And so my instinct said to me, there's something more going on here with her. She probably is here because there's something she wants us to help her with. And so I come marching in, ready to have this great teachable moment with my resident. And I stand there and I say, so do you mind if I ask you a question? How did you hurt your wrist? She was like, I fell. And I said, right, I know you said you fell, but like, how did you fall? Down. And I said, okay. So this might be really offensive or could come out wrong, but I need to ask you an important question. So did anybody grab you or hit you or harm you? Do you feel safe at home? And she stared at me as my resident looked on, and she says, you are absolutely right. That is offensive, and that did come out wrong. And I was like, whoa. I looked like hoping my senior resident just starts typing the EMR. That didn't go so well. And so I was embarrassed, and I tucked my tail between my legs, said, oh, well, we'll help you with your blood pressure, and I left. Thinking, oh, so much for this teachable moment that I was going to have, but I thought about her. And we've all had those patients where something in your gut didn't feel right, and you chart check them all the time and try to see what's going on with them. And that's what I did, and after a while, she just kind of disappeared from the chart and also from my thoughts. 2 years later, I come into clinic. I walk into the room, and there is sitting Miss Moore. She looks great. She's robust looking. She has on like this bedazzled denim outfit all the way like head to toe. I remember that. And she looks at me, and I look at her, and I hitch when I see her, and she goes, I remember you. And I was like, yes, ma'am, I remember you too. And she was like, do you remember me? And I said, yes, ma'am, I do remember you. And then she says, I wasn't safe. And I was like, oh. And immediately, like my eyes welled up with tears. And I have to say, I'm a crier. I just let go of the whole not crying in front of people thing anymore. And I said, but I asked you, and you said, she said, you let me back you down too easy. When people are scared, they say and do all kinds of things. Why do you think I came back to Grady the next day? I said, I don't know. She said, you did know. You let me back you down too fast. And it's not our job to like take abuse, right? But instinctively, I did feel that something wasn't right. I was senior enough where probably I could have tried some other things. But the main thing she told me was, sometimes you got to push. If you feel strongly about something, you got to push. Because I saw in your face that you didn't believe me. And even you watched me as I walked out of the clinic that day, and we were looking at each other, and you just didn't push. And I wished you had. So I remembered that. I remembered that pushing is sometimes a life or death thing. And I couldn't find that in a book. But let me tell you, it definitely altered the way I take care of patients. Pushing isn't always comfortable, though. As you saw, it can be embarrassing, right? And so this was a day with my ward team where we had admitted a patient with acute decompensated heart failure who had been on another team 3 days before. So our tradition at Emory is that we transition those patients back to the team where they've been for continuity of care. And so this lady, we saw her, we started her diuresis, we contacted the other team, and then as we're walking through the hallway, all jovial, this happy team here, this woman says to me, "Oh, doctor, y'all didn't write for my Percocet. I take 2 Percocet every 4 to 6 hours, and it's not on my chart, so y'all need to add that." And I'm in the hallway with my whole team and people out rounding and everything, the hustle and bustle of the hospital, and I go, "Oh, okay, well, you know what? I was looking at your chart. I didn't see anything about, Percocet, so will you allow me to just loop back to you? I need to look at your chart a little more carefully." She said, "Honey, you don't need to reinvent the wheel. I take Percocet. Why would I lie to you? I take 2 Percocet every 4 to 6 hours as needed, and I need it. And so I'm going to need you to write that right now. Just here." And she pushed a little, like, workshop on wheels to me, like, put that order in right now. And my team is kind of standing there looking uncomfortable, and I look at the patient and I say, "Ma'am, I need to come back because why can't you write for my medicine?" And I said, "Well, these medicines can be habit-forming sometimes, and so, just to do right by you." And when I said habit-forming, her whole face just fell. And then she stepped close to my face and said, "I don't want nothing from you." Turned around and walked away. I was like, great. Oh, man. So one thought was, well, this patient was going back to another team anyway. I'll never have to see her again in my whole life. But I knew something about this interaction wasn't right. And I remembered that other patient, Miss Moore, telling me that anger and extremes of emotion, whether very, very happy or very, very not happy, are usually have nothing to do with you. So I made up my mind to go back to her room. And let me tell you, as I walked back to her room, she was standing in the hallway on the door jamb like this. So it was very, very uncomfortable. And I start walking her direction, and the nurses are already getting ready to watch this go down, right? They are like, yes, she's about to get it. And I walk up to the patient, and I say, "Ma'am, I just wanted to come back and talk to you because it didn't go so well earlier." And before I could even finish, she pointed so close to me that she almost touched my nose and said, "I don't like you." And I was like, okay. I don't need you to like me. I just want to talk to you about this medication. I shouldn't have talked to you in the hall. I shouldn't have talked to you around all these people. I'm sorry you're in pain. I just want to better understand. She was like, "You should be ashamed of yourself." Gosh, this is terrible. And she says, "You're a black woman in this hospital where most of the people working in here who are doctors don't look like you, and most of the patients here do look like you, and you decide to tell me in a hallway full of people that you think I'm an addict?" And I was like, whoo. She said, "You think you're better than me, and I don't want nothing from you." Now, if I had not met Mrs. Moore and remembered what she said about extremes of emotion, I would have just let that be personal, and I would have just let my feelings be hurt and left. But I said, this isn't probably about me, so let me see if I can take a little more of this. And I said, "Please, please, please let me come in your room and talk to you, if possible." And finally, we go in the room, she sits on the bed, and she starts to cry and cry and cry. Her ejection fraction was 10 to 15%. This lady wasn't even 60. She could barely eat anything that she wanted to eat without going into an exacerbation. Walk anywhere. She couldn't lay flat in the bed that she shared with her husband. She couldn't do anything. And the only little thing that she really had some control over was just taking these pain medications, which she really didn't need. And in the end, what I remember the most her saying to me was, "We cool. Don't worry, we cool." But I also remember her saying, "It's not about you. And sometimes what you hear got more to do with where you at than what the other person say." That's exactly what she said. And that was another thing that, again, I couldn't read in a book, but has changed the way that I approach patients, particularly ones that are angry. And certainly in the environment where I work, I see a lot of angry and hurting people. She taught me that pushing sometimes isn't a physical act, but it's just waiting for the storm to blow over. When people are really, really upset, eventually they calm down. That works in marriage too, by the way, and with your kids. I'm just letting you know. This was my team in September of 2016, and this team reminds me a lot of the power of these three things: presence, peace, and permission. I know it was September because in September, that's football season, and I have a kid who plays football, and my motto for my kids in sports is make every game or die trying. So I pretty much build my entire schedule and life around getting to these activities. And this was in September. And so this particular day, my son had a game, and after my son's game, I had gone to meet my team who was on long call. They were gracious enough to allow me to round with them a little later that day. And the very last person that we saw on rounds that day, it was about almost 5 in the evening, was a woman who had advanced metastatic ovarian cancer. She'd come in for intractable pain, lower extremity edema, and shortness of breath. And so we were trying to manage all of her symptoms. Unfortunately, her family wasn't ready to have her become DNR, DNI, and so she wouldn't agree to that. She had one daughter, and her daughter was extremely upset about her mom's diagnosis, understandably. And so we would just manage her symptoms and try to navigate what we would do next when she got ready to leave the hospital. This patient was wise, though. And for any of you who've cared for people nearing the end of life, you know the clarity that patients can have sometimes in that time. And so each afternoon, I would just come and sit with her and talk to her. And after about 4 or 5 days in the hospital, on a Friday, she looks at me and she says, "I'm tired. I'm really, really tired." And I said, "Does this mean that if something happens and your body is trying to transition, that we should allow a natural transition?" She said, "I can't do that to my daughter yet, but here's what I need you to do. When it is time, when it is really just time and you will know it, and I'm getting close to that, I need you to tell her to let me go." I'm like, "What? No, I need you to say this so I can write this order." And she was like, "I can't do that." And so the very next day was a Saturday. My resident was off. We were rounding and we walked into her room. The lights were all out. The palliative care team was at the bedside. And her daughter was sitting there holding her hand, tearful, and she said, "My mama hasn't talked all day. She hasn't said anything." And I said, "Okay." And the nurse says, "She's hypotensive and, she's not making any urine. You guys have to kind of figure out what you're going to do next." And I said, "Okay." So I get a little bit closer to the patient and I touch her hand, and she opens her eyes and she smiles at me. So I knew she was there. This was voluntary. And I said, "Do you need anything for pain?" And she said, I said, "Do you need anything for nausea?" She said, I said, "Do you need me to do what you told me to do?" And she said. So I stood up and I looked at her daughter and I said, "Your mother is very tired, and she told me to tell you to let her go. But she needs your permission." And her daughter looked, and she looked at her mom. "She needs to know you'll be okay." And she said, "Mom, no, you did great with me. I'm going to be okay. I'm okay." And I said, "Okay, get your family here. Call them. If anybody is within an hour of Grady, get them here to her bedside." And that is what they did. This is her family at the bedside that day. That's my hand at the bottom, her hand at the top, her daughter, her best friend, her family. It was one of the most beautiful things I have ever seen in my career. But that permission piece was critical, because I can help you get to peace by making sure you're not in pain, but the permission part is really something that comes from the people who you love the most. When we got out in the hallway after that, the medical students, the team, me, we were unglued. I mean, crying, ugly crying, shoulder shaking crying. It was a lot of crying. And the students were so stunned, and I said, somebody lost their mother. That's something to cry about. And it's going to hurt sometimes, and it's just okay to let it. And I have to tell you guys that, I've done some cool stuff in my career. I've gotten some cool awards. I got to even talk to Anderson Cooper, who was easy on the eyes, by the way. But one of the biggest privileges I've had is to see my name in this obituary when I sat on a little pew in the back of this church for this patient's funeral. I'd only known her for 1 week. A little goes a long way. We hear a lot of stuff in medicine, people give you a patient and they say, oh, nothing to do. You got that sign out before? No concerns, nothing to do, awaiting placement. So I got a patient who was just awaiting placement. A person who'd had a bad pneumonia, had been in the hospital for 60 days, got trached and was waiting for long-term acute care. They tried to get him off the trach and get him off the vent over and over. It didn't work. Awaiting placement. All right. Problem is I had this medical student on my team, and you know how medical students can be. This medical student goes, Dr. Manning, so physiologically, I can't understand why this patient cannot get off the vent. But physiologically, why is it that, but he doesn't have respiratory muscle weakness, he didn't have underlying disease. Physiologically, that was the word she kept starting with. And physiologically, I didn't know. I knew I had 20 patients on my census. I knew this was one of them. I knew he was uninsured. I knew that placing him was going to take an act of Congress, and once I got him placed, I was going to be happy. I knew that. But physiologically, all that stuff she was talking about, because this was a patient that we didn't have a lot going on with. And I'm like, why does she keep bugging me about this patient? And so we decide as a team, because physiologically it wasn't making sense, that what we would do is we would treat him like he'd been in the hospital 2 days instead of 2 months. And so instead of us popping in real quick, waving and laying the stethoscope on him and walking out, we are going to come in, we're going to go through his whole presentation, we're going to carefully look at everything, but we're also going to talk to him about this. And so what we tell the patient is, sir, we don't have a physiologic reason why you cannot get off the vent. And so together, we need you to fight, and we need you to be team, we're going to be team better. And he was talking through his trach. So we would come in and he'd be like, team better. So this guy was depressed, so we started him on a SSRI. We tell PT, aggressively get him out of bed. Don't let him say no. Let's push him. And let me tell you what happened to this guy. First day, he's up a little bit more. They downsize the trach. They cap the trach. They get him in the hallway walking. And eventually he walked out of Grady to a subacute rehab without a tracheostomy tube. So 2 years later, I'm in the clinic, and I see this patient. And he says, you remember me? Team better. I got a girlfriend. I got a car. I got a job. I'm doing great. He had picked up weight. He was happy. And this patient was not even 45 years old when all this was happening. So this was a life-changing thing. And what he said was, you saved my life. You saved my life. And I didn't save his life. The medical student saved his life. So what I learned from that was that the lowest man on the totem pole can throw down a speed breaker that saves somebody's life. And saving lives isn't always sexy where you're doing chest compressions and throwing in lines. Sometimes it's just as simple as what you see and what you're willing to see, right? So what we see is a choice, and I learned to slow down a little and let people help me see things a little bit differently. So you guys probably wonder what happened to Mr. Farrell. Mr. Farrell did get out of the intensive care unit, even though the intern, didn't recognize that he was septic. And when he came out of the intensive care unit, there was one thing and one thing only that he wanted everybody to know. I never in my whole life want to be intubated again, and I don't want anybody to push on my chest and put me on life support, ever. So obviously he was DNR, DNI, but he also had been seen by the vascular surgery team who said, he is not a surgical candidate. Nobody can do anything about this ulcer on his leg, which was the source of his sepsis. And so essentially, I had a patient on the service now who had a dead limb attached to his body that had caused him to be septic, who didn't wish to be intubated or coded. And I just didn't sort of know what the plan was. And I had grown to really care about Mr. Farrell, so I didn't like that plan. So I went to my attending and I said, you got to do something. You gotta go talk to vascular and reverse his DNR, DNI so he can get his surgery and get his BIMPOP bypass, and then we'll make him DNR. But we got to do something. And my attending was like, let's go see the patient. Because that's what attendings do to you when you're all hyper like that. So he goes and pulls up a chair and sits down next to the patient and goes through the whole chart, goes through the whole history. And then he asked the patient what's important to him. Of course, you know, Mr. Farrell started talking about JoJo, the Jack Russell Terrier. So my attending listens and smiles and laughs and goes through everything. And it's very clear the patient never wants to be intubated again. So we walk out of the room, and he looks at me and he says, Mr. Farrell is dying. He needs permission to die. I was like, what? Because this is where I learned the permission piece from. He said, call his family. I said, oh, but no, his vitals are okay today. He said, there's something about a will to live that is a really powerful thing. And when this man feels like he can do all that he's got a good peace of mind and he has permission, he's going to transition. And I'm like, what? He said, call the family. So I start calling this man's family up, asking them to come to the hospital today. So they're all coming to the hospital, person after person, coming to see Mr. Farrell, coming to see Mr. Farrell. And at about 4:30 in the afternoon, there's this big commotion in the hallway. And we come out in the hallway and we look to see, what's going on out there. And up comes my attending, all, 6'1" of him walking down the hall. And behind him is somebody holding a little Jack Russell Terrier in their arms. And this was 1997. Now they have all these care dogs and everything. This man brought a Jack Russell Terrier into the hospital to help give Mr. Farrell the permission to go. That dog jumped on his chest. That man cried and cried. His grandson was at the bedside. His kids were at the bedside. And they said, I will take care of JoJo. I will take care of him. He's in good hands. I love your dog. He'll be fine. Because that was what Mr. Farrell cared about the most. And my attending stepped out with me after that and said, look at Mr. Farrell. He's peaceful, and he's been given his permission to rest. Don't be surprised if when you sign him out and you come back up here tomorrow that he's not here. And I was like, what? And the next day, I went to his room, and his bed was clean, and he wasn't there. I asked the nurse what happened to Mr. Farrell, and she said, oh, he went on to glory last night, and it was a beautiful thing. And it was. Here's our take-home messages. Pay attention. It's a privilege to get to do what we do, and what we see is a choice. Try to put the pieces together. Some things in medicine don't make sense, but most things do. 3 minutes is a little, but it can mean a lot. Turn your whole body to people. Give them your full attention when you can, because it can make a difference. Don't size people up, and don't assume anything until you look with your own eyes, and avoid unnecessary shortcuts, because we're all so busy. And this is advice that I'm trying to take for myself too, trust me. Be present, not just in the hospital with your learners and your patients, but with your family too. Soak up wisdom at the bedside. No matter how busy you get, carve out 5-10 minutes just to sit with somebody wise. I try to do it every single day when I'm on the hospital service. Be brave. Use your powers for good and advocate outside the box. It might even involve bringing a Jack Russell Terrier into the hospital. Notice things. This was a patient who turned 79 that I was taking care of, and her family couldn't find a card that says 79. So you do the math. This is the chapel at Grady that I'd never seen before until I stopped one day. Dig a little deeper. This patient told me she was from Alabama, and then I learned that we went to the same college. She graduated from Tuskegee in the 1940s and had known the Tuskegee Airmen. And I brought her a blanket to take with her when she went to hospice. This was a patient in the cafeteria who had been told by our former chair, now deceased, that if she lost weight, it would help her heart. And she never got to thank him, and she'd lost 150 pounds, and her heart was doing better. This was a nurse that I saw comforting a patient in the hallway. Trust your instincts. It's not about you. Keep calm and wait for the storm to blow over, and never underestimate the power of the little things that you do. Recognize the power of your influence. This was my senior resident who wore fancy socks every day, and this is the end of the month with his interns. And be intentional about it. A lot of this stuff isn't about us, right? So what you do, somebody's watching you, and it's permitting them to be. Be present in everything. This was a little girl who walked up to me at Grady and said, "Are you a doctor?" And I said, "Yes, ma'am, I am." And she's like, "I can be a doctor." And I said, "You can." And she said, "My name is Pretty." And I said, "Your name is Pretty?" And she said, "Yep, and my middle name is Lady." I said, "Your name is Pretty Lady?" She said, "No, that's just what everybody calls me." This was a day at Grady Hospital where I was working with these 3 attendings, all African-American women, and I recognized that in that moment, that 50 years ago to the day that we were sitting there, not one of us would have been allowed to have privileges there. This was when I ran the half marathon in Paris, and this was when I went with my son to a Black Lives Matter rally. And this was when my son did a science fair project on the 5-second fork rule. Spoiler alert, if you drop your fork, as long as it's not wet, you can just keep eating with it. That's scientific. Be present with everyone, and especially remember that becoming is better than being, because this whole process of what we've been talking about is just stories of becoming, right? We're still always trying to figure it out. This is my son Isaiah running in a cross-country meet. He is slow. And he was in dead last, so I got a lot of good pictures of him with nobody around. But he was trying, and each one he got a little bit better each time. Compare that to his brother in the green, who's a little faster than him. But it's all still a story of becoming, and I value it all. And most of all, push, because it could save somebody's life. And even if it embarrasses you a little, and the nurses are laughing at you, and people are talking under their breath, just that little bit of time that you stick around could make a tremendous difference. Just acknowledging a few people. This is Dr. Olds, who talked to me those 3 minutes. I ran into him at ACP a few years ago, and was really happy to be able to tell him that. Our students, of course, family, and especially the patients with whom we get the privilege to work and whose lives we get to step into every day. That's my motto at work. And that's all. Thank you. And thank you for coming out in the snow. I thought I was going to just talk to this one chair. I know it's, you guys have to go to clinical places. It's about 2 more minutes to go. If you have any questions, I'm happy to answer them. Yes, sir.
That was great.
Thank you.
And I'm wondering what your thoughts are about, I think a recent publication on the residents spend on an average day an hour and a half with the patient and 5.5 hours with the EMR.
Mm-hmm.
So a lot of people talk about how this type of lessons and learning is getting lost. What are your thoughts? How do we fix that? They just don't have time to.
Yeah.
Or they don't think they have time to sit there with the other pressures.
So the one thing I'll say is that it's like a we. I do think it's a we that thinks we don't have time, right? Because there were people rushing back in 1996 when I was an intern, and people who still move slow, just as there are millennial learners who are empathic and who spend time with patients. But this is what I do think. We do not have that much time, and we do have to send people home now. So the thing I tend to think is that you slow down and speed up. That's something that I think of. Specifically, what's meant by that is that there's ways that you can connect with people in a short period of time that goes a long way. I tell the team, when you come into the room and somebody in pain, slow down your body movements, be psychomotor retarded, sit down, bring the tone of your voice down even. Make sure that the patient sees you looking at them. Try to find out one thing unrelated to why they're in the hospital and remember it when you come back. That doesn't take that long. So the things I do think that we could do is try to model ways to connect with people in meaningful ways more quickly. And you've all met a person who's met you in a moment, and something about the way that they look at you and talk to you in just that little moment, you feel important and valued. And those are just things I try to watch in people to do, and I try to mimic a little bit more. So I do think there are ways to work around our time constraints. As far as the EMR and everything goes, that is a very, very big challenge. But I do have some little strategies with my teams where I say to them, I want nobody to know, nobody should know your patient better than you. And I am going to be in competition with you to know your patients better than you. So when we start rounds, I'll be like, hey, did y'all know that one of our patients on our service used to work for MARTA when they first opened the train rail? Who is that patient? And nobody will know. And I'll be like, it's your patient. Which of your patients is it? It's like, oh, you need to find out. So I always try to find out little things about the patients. And then by the end of the time we're together, the whole team knows all these things about the patients. And I think that makes that time richer. Other questions? Oh, sorry. No, she didn't get Percocet. She didn't get Percocet. And, when I looked through her chart, she really didn't even take Percocet that much. It was a control thing. And usually because she would get angry, it would just wear people down. And then she would just kind of get it. And then she would be on to something else to be upset about. So she was just hurting. Yeah, she didn't get Percocet, not even from the next team. I appreciate you all's attention. Soak up some time at the bedside with the patients. They're awesome. Thanks.